Welcome to this instructional review on the surgical anatomy and electrophysiology of the facial nerve. This session outlines the relationship between anatomic segments and stimulation thresholds observed during intraoperative monitoring. We will progress from the intracranial root entry zone to the extratemporal branches, concluding with a real surgical example. The full extent of the intratemporal and intracranial facial nerve is encountered during transtemporal surgery of CP angle lesions. Middle ear and mastoid surgery is localized to the intratemporal segments. These procedures include tympanomastoidectomy, stapedectomy, and others. Parotidectomy usually requires access to the extratemporal distal segment, where the nerve exits the stylomastoid foramen and enters the parotid gland to innervate the mimetic facial muscles. Thickness of intratemporal facial nerve epineurium. The thickness of the facial nerve epineurium varies along its intratemporal course. It is thinnest in the horizontal segment, measuring roughly 0.05 millimeters, increases to about 0.07 millimeters at the second genu, and reaches approximately 0.13 millimeters in the vertical segment. This gradual thickening is clinically significant. A thin epineurium in the horizontal portion makes the nerve more vulnerable to surgical manipulation, whereas a thicker epineurium in the vertical segment provides greater mechanical protection and may lower the risk of iatrogenic injury. These variations also influence EMG stimulation thresholds. Regions with thinner epineurium conduct more easily and require lower current to evoke a response, while thicker segments may require higher current levels. Facial nerve in the parotid gland. After exiting the stylomastoid foramen, the facial nerve enters the parotid gland where it divides into its main trunks and terminal branches. This region is of critical importance in parotid and facial surgery, as injury to even a single branch can result in localized facial weakness. Within the gland, the main trunk typically bifurcates into upper and lower divisions, which further branch into temporal, zygomatic, buccal, marginal mandibular, and cervical branches. These branches radiate outward in a fan-like pattern, forming a plexus that lies between the superficial and deep lobes of the parotid gland. Understanding this branching pattern helps surgeons navigate safely during parotidectomy, facial reanimation, and nerve grafting procedures. Electrical stimulation thresholds here are generally higher, around 0.3 to 0.5 milliamps, because the branches are encased in fascial tissue and partially insulated by glandular stroma. Now let's begin at the intracranial segment. At the brainstem root entry zone, the facial nerve lies in direct contact with the cerebellopontine angle cistern. This segment has no epineurium, only a thin arachnoid covering. Triggered EMG requires roughly 0.05 milliamps for depolarization with a monopolar stimulator probe. In practice, I typically use 0.07 milliamps to ensure a consistent reproducible response. Because the nerve is uncovered and highly conductive, stimulation here is extremely sensitive. Intrameatal segment. As the nerve enters the internal auditory canal, it becomes enclosed in a dural sleeve. While dissecting within this region, the stimulation threshold increases, generally between 0.15 and 0.3 milliamps, depending on tumor or dura thickness. Once the bone over the internal canal is thinned and removed, the underlying fibers again behave as raw nerve tissue, with no epineurium but still under a delicate dural veil. For this reason, a higher level is required to stimulate the nerve through the dura. Labyrinthine segment. Within the labyrinthine segment, stimulation begins around 0.10 milliamps, decreasing towards 0.05 milliamps as bone is carefully thinned. Here the epineurium is only beginning to form, so the nerve still acts almost like a bare conductor. The overlying bone is reduced to only a few microns thick and in intimate contact with the nerve, a zone requiring extreme delicacy during exposure. Geniculate ganglion. The geniculate ganglion also responds at relatively low current levels. I typically start at 0.15 milliamps, though stimulation may occur even lower due to the presence of vascular channels that enhance conduction. If the ganglion is encased in bone, the required current may rise, occasionally reaching up to 1 milliamp when the osseous covering is thick or irregular. Horizontal segment. Within the temporal bone, the horizontal segment runs from the postgeniculate location to the second genu, passing over the oval window. It is surrounded by thin perineurium and lightly conforming bone. Stimulation typically requires between 0.5 and 1.0 milliamps, but sometimes less. At this point, the nerve is well protected, yet still accessible for intraoperative mapping. 20% of patients have a dehiscent nerve over the area of the oval window, which can stimulate at much lower current levels. It is important to check for this common anomaly when working in the middle ear. During stapedectomy and cholesteatoma removal, it may trigger a passive free-run EMG response when touched. This underscores the importance of continuous free-run EMG monitoring in addition to triggered measurements. Oval window region near the oval window, the nerve may be partially or completely dehiscent. When fully exposed, thresholds can drop to 0.3 milliamps or even 0.15 milliamps. A practical and safe range for detection is 0.3 to 0.5 milliamps. This is an ideal point to use a safe scan function to calibrate the stimulator and set a stable working level, a technology that I am working on with the NCC Electrophysiology Company and hope to present in the very near future. Second genu. At the second genu, where the facial nerve bends downward, thresholds average 0.7 to 1.0 milliamps while still within bone. Values can be lower when vascular channels or thin bone facilitate current spread. Here, the epineurium thickens progressively, continuing along the descending intratemporal course. Vertical segment. The descending or vertical segment generally requires 0.7 to 1.0 milliamps through thin bone. If the bony canal is partially opened, less current may suffice. This portion balances electrical responsiveness with structural protection, a region of great importance in mastoid and skull-base surgery. Stylomastoid foramen. At the stylomastoid foramen, thresholds increase to about 1.2 to 1.5 milliamps. This reflects the fibrous and fascial tissue density at the nerve's exit from the skull. Here, the nerve transitions from the bony canal into the soft tissues of the parotid gland. After emerging from the stylomastoid foramen, the extratemporal segment of the facial nerve can be stimulated at low current once the trunk is fully exposed. Typical thresholds range from 0.3 to 0.5 milliamps on a clean dissected surface. Although the epineurium here is relatively thin, the nerve lies beneath layers of parotid and masseteric fascia, and this soft tissue covering influences the effective threshold. For localization, I usually begin with 1.0 to 1.5 milliamps, then reduce as soon as the nerve is visually confirmed. Mechanical feedback can assist electrical mapping in this region. Gentle tapping of the trunk or direct contact with forceps produces corresponding EMG activity and helps refine the exact position. This combination of tactile and electrical cues ensures precise identification while minimizing unnecessary current exposure. Clinical correlation, acoustic neuroma. Finally, we apply these principles to a large left-sided acoustic neuroma. The MRI shows a large tumor filling the cerebellopontine angle. During translabyrinthine removal, continuous monitoring confirmed progressive facial nerve responses at the expected segmental levels. At the conclusion of resection, stimulation verified intact conductivity along the preserved facial nerve. Postoperatively, the patient exhibited only a mild House Brackman grade 2 facial paresis, which resolved completely to normal function within 6 weeks. This case highlights how anatomical understanding and precise monitoring work together to achieve both total tumor removal and excellent facial nerve outcomes. The subsequent video clips were taken just after total removal was achieved and facial nerve integrity was confirmed with electrical triggered EMG. Note that the expected levels are manifested, supporting the observed clinical outcome. Thank you for your attention. I hope you enjoy the films. Please subscribe to my channel to see more content.
Over here. Okay, we got something here. Now put it down to 0.7. See, here at 1.0 it does nothing. 0.7. Okay, okay, there it went because it's a little raw bone. Here it went. Look. Here, tap. Leave it right there. We stop talking for a second, Becky. You hear that? That's sub-threshold activation. So the system taps, it tells you there is, it is recording action potential, recognizing as action potential, but it's below 100 micro. So I want to put the stimulator down to 0.1. We need a stimulator. Mini. Yeah. No. Zero jeden. Good. Yep. Now, I expect that it may stimulate at this level. Yeah, see, so right here, I'm getting very nice stimulation at 0.1, very high amplitude. See, we have a maximum of 792. Put it down to 0.07. 0.07. Yeah. Now, still getting. Put it to 0.05. Okay, 0.05. You're still getting it. So that's because right here we have just only a little bit of exposed, just basically periosteum or endothelial cover with raw nerve. And that's why we're able to get that level. Okay? Good. Go ahead. Yeah. Again. Good. Gently. And there. Go ahead. And good. What about that band? That band, is that something? No, it's not. Okay, so but that's capsule, so we're going to leave that down, okay? And now, let's do this. Go do that again. Go ahead. Stimulate again. Right on the nerve. Good. Again. Good. Okay, and you're at 0.07. Very nice. So there was a little stronger on the other, but she does move on the left.
Yes, on the left a little
She
bit.
does, yes. There it is, yeah. Let's just wait till we get a real good one. There, that was one. But that's common, so let's see. There, that was one. A little tiny one. She coughs again. When you extubate her, for sure she'll do it. You know? Oh, I saw a flicker in the lip, so that's good.
It's very hard.
Ask her again.
Proszę spróbować jeszcze raz się uśmiechnąć.
Right here. Yeah.
O,
See?
o,
Oh, that good.
jeszcze raz tak samo.
Again,
Jeszcze raz tak samo.
Yeah, good.
Now let's watch another film. This one was taken while I was instructing a young doctor on how to safely find the facial nerve during parotidectomy. You will note the use of the probe as a seeking tool as well as a confirmation of both location and integrity tool. Both passive and triggered EMG are helpful when working around the facial nerve. I typically combine the use of the EMG monitor with the microscope to achieve the best possible results for my patients. You will also note that frequent adjustments of milliamp stimulus intensity are required to take full advantage of the EMG system. I am actively working on redesigning these systems with the NCC Electrophysiology Company to automate and facilitate this process. At this time, I want to point out another important point. Each system, each probe type, and each stimulus protocol, whether monopolar versus bipolar, and the pulse width and event threshold settings vary slightly, so it is essential when selecting a system to use one that is configurable and consistent so that you become accustomed to the response patterns. Some systems are designed to work as standalone with auditory feedback, while others require a technician or other professional to interpret the responses. I personally prefer standalone systems, though it is also important to develop a consistent routine in monitoring, regardless of which system you decide to use. During parotid surgery, we monitor the facial nerve using 4 channels. This allows us to stimulate and distinguish individual branches. Stimulus delivery audio, okay? You don't want continuous tone for stimulus delivery because then you're going to be giving the stimulus, and there's going to be a continuous tone when you're trying to hear the activity tone. Okay? When you're looking specifically for EMG, you want brief tone. Like that. You hear that beep? That tells you, that sound, beep, tells you that the circuit's connected, and that's all you want. You also want to see that your threshold is set to 100 microvolts, and this is also has to be changed. You see volume 15%. It should be 50 at minimum. That's the first thing that we have to change, because the other day, remember, you didn't hear anything, because that's all. We're going to find, so I'm going to make a mark. It tells me that that's where the marginal mandibular nerve is crossing the mandible. And it's a low, relatively low threshold, but there it is, and that's an action potential. Okay, so that's real. Okay, now, so we see the tumor, the point where we're able to activate the marginal mandibular nerve, the natural crease, and now we're ready to begin. Okay, all right, good. This is parotid tissue. This is subcutaneous fat. This is parotid fascia. In this area, we're very safe. Okay, bone, sternomastoid. So you want to expose bone right there, and you want to expose sternomastoid. Okay, now, look, put your finger in there, feel that. Okay, nice and open. There's the jugular vein. Yeah. You put your finger in there, you feel the carotid pulsation, but look how nice that is, okay? Mm-hmm. Now, the first thing, put it up now to 1.5. 1.5 is a good enough level. It's like, it's about 3 or 4 times what I would expect a raw nerve at this location to get. So, we're going to be, the first thing I'm going to do, I'm just going to look here, and I'm going to show you a couple of things that are commonly mistaken for the nerve. This. Now, did you hear that? I'm going to do this again. Did you hear beep, right? Listen. And look at that 1.5, right under the 1.5, that number changes to 1.5. You see? Because that tells you the current that's being delivered. And that short burst is telling you that it's connected. Okay, if you have whole time, so you don't know. This is just a band of tissues and an artery. You see? Look, this vessel. So this is often thought of as the nerve. And it's always here. So that's the first thing that's not the nerve. Okay? Now, I told you it's going to be a rough spot. Okay? I'm going to feeling through. And I'm checking around. Now, it's not high enough. Okay? To get feels from there. See that? Look. Did you see that? Right. So it's deep down there. Okay? It's about that deep in there. You see? So look at that. That's about that depth right there. And it's still not exactly this. So we know that this is very safe. Now you're going to sit down, and the first thing you're going to do is you're going to bipolar this artery and take it. Okay? Bipolar, I'm going to show you something. Don't bipolar it here. Because then you're going to have all this tissue in your way. All right? Bipolar it here, but everyone's afraid to do that because they're afraid the nerve's here. But you know that the nerve's not here. So you're going to bipolar and you're going to pull away like this. Okay? Now, didn't I tell you the nerve is going to be in that direction? Okay. Because that's between, right about halfway in your mind, between the tragal pointer and the mastoid tip. It's right about there. Okay? And that's where it is. It's about between tragal pointer? Yeah, between the tragal pointer and the mastoid tip, about halfway, and about a centimeter down. And that's what I did. I put the probe gently, about 1 centimeter, down right there, and that's where the sphygmomastopharyngeum is. Okay?
Put the stim down to 1. Down. Dollar, yeah, down to 1. 1.1, good enough. No, 0.9, good enough, good. Now stimulate in that area where you said to yourself, oh, is that a nerve? Right in there, yeah, go ahead. Okay. Nothing, right? Good. And you see that little bit of tissue right above your stimulator, that, right? Now you're going to bipolar, you're going to cut this band. Now, do that again. Now we're stimulating the nerve right where we thought we saw it. Right there. Good. Stop now. Stop. Because 0.9 is a little high. So now let's go down to, put this down to 0.5. Okay? 0.5. Try again in the same spot at 0.5. Okay? So that's pretty good. Now let's go down to 0.3. Because raw nerve in the parotid, you should get at 0.3. Okay? So now go again. There you go. Okay? So now you know you're there. So now you have to expose that a little better. Get it there. Okay? Pretty close. Yeah, so just spread the tissue over it. And you want to expose that. Yeah. Okay. That's good. There. Okay, good. Now, see that depth? You're at 03 right now? Yes, you're 03. So see that depth. So I need to take this thing out. Right there. Right on the. Go ahead. I need to take this thing out. Okay. Right there. Go ahead. Spin. There. Okay. Now, so you need to take. You can take your instrument, or you can use your bipolar. Just take the white thing out. Take that stuff that's just there. It's a little fascia on top of it. Bipolar, just spread it. Yeah, get that out. That's good. Cover. Now cover. And the body. Right there. Good. That's it. That white is it. That's it. Okay. There. Right. Okay. That was a spontaneous act. Look. Okay. There. That's good. Got that. That's a spontaneous movement. That was completely spontaneous activity just from stretch. Now, good. Now you stick to it. Now, follow the nerve out. There. That's good. Good. That's good. Spread. Now, what's lateral to the nerve? The bipolar and cut. Lift up your hand. Yeah. Lift. There you go. Lift. And then bipolar. Okay? See? You lift to get it away. Right? Down and lift. Okay? There. Now everything that's if you bipolar on your gas is completely safe. Don't pass 20. That's completely safe. You have to lift. Now, okay, now. There. See? Good. So there's the same. There are sensory branches. That's an artery. It's probably an artery. See that thing? Yes, that's probably an artery. Now, that's the thing go up. Up. Yeah, that's right. Come through. Poke through. Poke. Good. Good. Now, poke through. Yeah, go ahead. Poke through the plant flows. Now get. Yeah. Much better way of understood. Good. Here we go. Good. Open that up. Good. Good. Keep going. Okay. Right. So that's a 0.3. Yeah. All right. Ready? And you see there's activation, especially on the lower end. See? Yeah. The mentality. So we know that the mitral is. Where exactly are you pointing? Can you show me? Let me just record that, all right? Upper. Just record it. And then upper. All right. Okay.
I hope you enjoy the films. Please subscribe to my channel to see more content.